This is going to be on IBD patients and the COVID protocols that we follow. Dr. Rupa Banerjee is a well-known figure both nationally and internationally in this field, and she is going to take us through the role of COVID protocol, the present COVID protocols in IBD patients. Over to you, Rupa.
Thank you, Dr. Manu. Continuing with the series on COVID, the talk assigned for me today is COVID and IBD. How do we prevent? How do we manage? And of course, vaccination. We all now know about the COVID-19 pandemic and how the entire global is shades of pink and deep red, the extent and severity of the pandemic. At the same time, IBD is a chronic lifelong disease. You can see Picasso's picture over there signifying the suffering, a chronic lifelong condition. So these are now coming together. As the world continues to grapple with the COVID-19 pandemic, management of patients with IBD requires special considerations. Why? Because patients are often malnourished and immunocompromised and therefore high risk. The medication protocol may need to be modified. There are so many issues, particularly in this part of the world. Hospital visits are difficult, performance of elective procedures, surgeries, infusions. The low resource settings has also shown us that, access to care is difficult, availability of drugs. The rural and primary healthcare network is actually ill-equipped to deal with IBD with limited resources, management facilities, or physician awareness. In fact, we had conducted a questionnaire survey of the impact of COVID-19 on the management of IBD. More than 1,000 patients were contacted. What was interesting is 35% of patients did not get any medical consultation even when they had symptoms. They could not get access to the local physician. Only 7% patients visited the doctor in person. Again, among patients on biologics, this was maximally impacted. 22% missed their scheduled dose for causes like inability to visit the infusion center due to lockdown, and again, non-availability of a local infusion center with expertise. Most places said that biologics, we will not take the risk. 10% almost stopped their IBD medications. So what are the management issues with IBD? Number one, what is the risk of COVID-19 in patients with IBD? Should patients modify their therapies during the pandemic? For patients infected with SARS-CoV-2, should their IBD treatment be modified? Post-COVID, when should treatment be restarted? Should IBD patients be vaccinated? Does immunomodulatory therapies impact antibody response? So the first paper that came to our mind, this is important study in our first analysis of the secure IBD registry. We are all a part of it, and this is a global effort to, on our knowledge about the impact of IBD therapies in the setting of COVID-19. As of February 2021, more than 5,000 patients were analyzed, and it was found that the hospitalization, ICU admission, mortality rates were comparatively similar to the general population, the population without IBD. The risk factors were comorbidities, active IBD, older age, use of steroids, as I just mentioned, obesity. In fact, even 5 aminosalicylates in a few studies have been shown to have possible negative outcome, but smaller studies, and this field is actually evolving, thiopurines and combination therapy. This, I think, in current opinion of gastroenterology, is a very elegant overall review on optimal IBD management during the pandemic. The key points are patients with IBD are not at increased risk infection overall. However, when there is increased disease activity, obesity, corticosteroids, the risk increases. Non-live COVID-19 vaccines should be offered to patients with IBD regardless of immunosuppressant use. The AGA clinical practice update on management of IBD during the COVID-19 pandemic sums it up very well. Patients with IBD, once again, do not appear to be at a higher risk. Patients with IBD who do not have infection should not discontinue their regular IBD therapies and should continue infusion schedules. Those with asymptomatic COVID-19 should withhold the thiopurines, methotrexate, and tofacitinib. Dosing of biologics should be delayed by about 2 weeks. Those with symptomatic, once again, biologics and immunosuppressants should be started. It should be restarted only after complete symptom resolution or when follow-up viral testing is negative. The severity of IBD and the severity of the COVID-19, we have to have a careful risk-benefit assessment and then decide on which treatment should take priority. So patient advice during COVID times in simple words, because this is what we are being asked over and over again. Number one, during this pandemic, they should continue treatment. Having IBD does not appear to increase the risk of infection. Instructions for patients with IBD who develop COVID-19, stop immunomodulants, stop biologic therapies, contact your local physicians. Can restart therapies after complete resolution of COVID-19 symptoms, minimize risks. Stay at home, avoid colonoscopy, non-invasive testing, fecal calprotectin monitoring, report early if there is a flare. Overall, it is important to remember majority of patients with COVID-19 actually do recover because anxiety levels are very high. When should we restart IBD treatment? The timing is influenced by clinical severity of both IBD and COVID-19. Those with mild COVID-19 symptoms, earlier restart by even 10 days is recommended. For those with more severe COVID-19 and well-controlled IBD, a delay in IBD therapy restart. It can go even up to more than a month. This is a very nice paper by Corey Siegel et al. At JCC published this month. So summarily, management of IBD therapies in the setting of COVID-19. No symptoms, no testing, IBD patient. Do not withhold IBD therapies. Try to reduce corticosteroids. No symptoms, but asymptomatic COVID, withhold IBD therapies for a minimum of 10 days. If positive and symptomatic, withhold IBD therapy. When to restart therapy? Non-test based, at least 3 days after recovery. Recovery meaning resolution of fever, improvement of respiratory symptoms, and at least 10 days have passed since symptoms first appeared. The other, of course, is the test-based strategy practiced in most of the European Union. Above clinical parameters plus 2 consecutive negative COVID-19 molecular assays more than 24 hours apart. Vaccination strategy is an evolving data, and the data, particularly for Covishield and Covaxin, is very limited because most IBD patients have been excluded from phase 3 vaccination studies. However, IBD patients taking biologics achieved a positive antibody response to the vaccines, and that is an important finding because published in Gastroenterology, it allays a lot of fears that vaccines do work. Important results have just come out. This is the first 2 papers from the Clarity IBD study. The first result, however, is that patients who were on biologics, fewer than half of them had detectable antibodies even after a COVID infection. The second study, this shows that after a single dose of vaccine, only 1/3 generated antibodies. However, when the second dose of vaccine was given, the antibody response rose significantly, indicating an effective response after 2 exposures. So this is very important information, particularly now that the doses single dose, the dose between the gap between two doses are being increased, that patients who are on biologics should be considered a priority for a second vaccination to develop some effective antibody response. We at the IBD Emerging Nations Consortium have actually come out with a position statement regarding biologics, that all should be vaccinated more than 16 years of age. Any vaccine type is suitable, whichever is available based on the country. It should be given a priority status because these patients may develop a more severe disease. And two doses, IBD patients on immunomodulators have suboptimal antibody responses. Two doses of vaccine is leads to seroconversion in a better way for IBD patients. That is another recommendation. So this is available at the website, the more detailed, and you can have a look as it is updated every month. The AIG experience, what did we see? Out of 61 patients of IBD who had COVID, we found that asymptomatic were 14 and 47 were symptomatic. Active IBD was only in 16 patients. When we saw the CORAD score, the COVID-19 severity, or the hospitalization, it appeared that it is the same as we were seeing in the general population. Majority had mild disease, only 10% had roundabout severe disease. COVID symptoms reported were similar, again, as in the general population, but watery stools was perhaps more common here, creating the dilemma whether it is because of a flare of ulcerative colitis or COVID-induced. Our dilemmas were, there were two patients of small bowel Crohn's disease who had perforation, which was managed conservatively. We think that possibly COVID could have precipitated that. One patient presented with active flare for biologic therapy, but symptoms subsided post-treatment with remdesivir. Now, after 3 months, the patient is symptomatic again. We don't know how that happened. 4 known ulcerative colitis patients with no fever or pulmonary symptoms presented only with diarrhea as a flare. 11 patients with IBD flare-up within 2 to 4 weeks of recovery. This meaning perhaps because of stopping of drugs and highlighting the importance to restart drug therapy. IBD medications, most stopped medications, as you can see with the orange, about 38% continued the mesalamines primarily. Remdesivir was taken by 13 of the 14 hospitalized patients. Biologics were stopped post-infection, and there were 12 patients on biologics. What we found that 50% of the patients who were on biologics actually had moderate to severe disease. The numbers are small, but indicates that perhaps people on biologics may be developing a more severe disease. Our protocol is very simple. When patients come with active IBD symptoms, we check whether there are symptoms of COVID-19 or there is a recent flare with diarrhea, or there are no symptoms of COVID or flare for more than 4 weeks. If there are symptoms of COVID-19 or a recent flare, we go for the test. Otherwise, we take it that it is an IBD relapse unrelated to COVID-19. In that situation, we confirm inflammation by a non-endoscopic approach, including fecal calprotectin, assess for the activity of IBD. If it is mild, we just go for topical therapies, oral budesonide, symptomatic therapies. For moderate to severe disease, we treat with existing therapy, thinking that benefits actually outweigh the risks, of course, trying to avoid thiopurines, methotrexate, and fastidium. If the patient is in remission with no symptoms of COVID-19, we continue IBD therapy. If it is there are any symptoms suggestive of COVID, we check for SARS-CoV-2. If it is positive, the patient with IBD has a positive, we assess for the severity of the COVID-19. For mild COVID-19 cases, we taper corticosteroids, switch to budesonide, continue the 5-aminosalicylates, budesonide, rectal therapies, enteral nutrition, withhold immunosuppressants and biologics. For moderate to severe cases, the focus is on treatment for COVID-19. That takes priority. The other, as for mild COVID-19, is kept in mind, and on a case-to-case basis, a judgment is made. Resume therapies after symptom resolution, or when SARS-CoV-2 retesting is negative, or after 4 weeks of detection. And as I said, these decisions are sometimes case-to-case basis based on the severity or the type of IBD symptoms. Very severe small bowel Crohn's disease, we need to restart the biologics at the earliest. Consultation for follow-ups is another very important factor in our protocol. The reason is these patients are worried. We need to allay their anxiety. They need to continue medications, and we are now constantly available online. And as you can see here, this is Team AIG IBD. We follow protocol all masks throughout the year as per protocol. Thank you. And over to you, Dr. Manu.
Thank you, Rupa. That was a very elegant presentation on the status COVID, the protocols we follow, what we should do for vaccination.